grant. So minor correction there. So today we're going to talk about what is the co-op and how to get engaged. We don't have any conflicts of interest to disclose. So first question is, what is a practice-based research network? You'll see in the title slide, it was PCBRN, not PBRN. So the old term PBRN, practice-based research network, has been sort of expanded to include the concept of engagement with community. So the original PBRNs were funded by AHRQ back, I think, in the 70s. The definition they came up with at the time, and which is still active, is that it's a group of ambulatory practices that are devoted principally to the care of patients. So it's where care is actually taking place, but they are affiliated, come together with a mission to investigate questions that are related to how practice actually proceeds in primary care settings. So the Northern New England Co-op, PCBRN, used to be called the Dartmouth Co-op, and it's expanded its scope in terms of who's supporting it and the collaborative agreements with the Northern New England Co-op or CTR. So voluntary network of primary care clinicians and other health professionals, primarily in New Hampshire, Vermont, and Maine, though we have had ongoing members from upstate New York throughout the life of the project. It is coordinated and supported in the Department of Community and Family Medicine at Dartmouth, and then obviously has support from the NNE CTR in collaboration with we have the distinction of being the oldest PBRN in the country, established in 72. And when you look at our network, and I think one of my next slides has a map of where they are, but they're made up of the range of primary care clinicians, family medicine, general medicine, peds, and includes nurse practitioners, PAs, MDs, DOs. And we welcome other interested groups as well. And then the governing board is representative of all of these disciplines. So this map shows the participants or co-op sites. And these, if you can see on the left green bar there, they represent solo practices, group, private, hospital, FQHC, the common types of practice arrangements, including academic practices. And the legends at the bottom show the Dartmouth affiliated programs are in green. The UVM Health Network clustered in the upper left are in blue, and then the Maine Health through Maine. And then the FQHCs and independent practices that are scattered throughout all three states are represented in orange. And you can see that some of the academic affiliated practices, the size of the circle represents the size of the practice. And you can see that the affiliated practices are on average bigger, and most of the independent and FQHC practices that are in our network are fairly small. And this is probably fairly representative of how primary care is practiced around the US. So we wanted to talk a little bit about research in the NNE Co-op PCBRN. And this slide has 4 bolded bullet points to kind of represent or outline the types of research that occurs in a PCBRN. So the research generated directly in the practice is designed to really look at relevant day-to-day problems that can only really be investigated where they occur. So that's sort of the pure research coming out of a problem that someone's trying to solve in their day-to-day practice. We've thought a lot about the continuum between quality improvement and research, because quality improvement is prevalent in really every aspect of healthcare, from inpatient, outpatient, and everything in between. And it's usually trying to solve a problem. And if you have a well-designed QI project with robust data collection, it really veers over towards being reportable as research. And there's obviously differences in terms of how you approach IRB and patient identification and everything, but there is this continuum of what can be learned and reported across that QI research spectrum. Many practices and many healthcare organizations have fairly robust quality improvement programs and staff. So having that knowledge and depth in a practice or organization can be super helpful. The third bolded bullet point is about data extraction from care delivery systems and from EMRs. And so obviously the co-op dating back to 1972 predates all EMRs. Really we've seen an explosion of availability of information with the adoption of EMRs in the last 15 years or so. Data extraction has some advantages of being relatively inexpensive, depending also on how it's collected and whether it skews toward the QI. With identified information, it can actually be very helpful for improving the practice, the patient care directly in an individual practice. And then more broadly may help guide clinical practice if it's generalizable. Data extraction tools and reports are already in place as part of regulatory compliance. An example being, chronic disease metrics such as A1C, which are, most quality improvement organizations or accrediting bodies have that, and hypertension metrics, et cetera, as metrics that they're looking to be reported. And then the last bullet point is around research subject recruitment. So the other way to use a PBRN or to collaborate with a PBRN is for specialty investigators who are looking to recruit subjects with specific characteristics who might be eligible for their study. And of course, EMRs can also be very helpful at identifying potential subjects, depending on the queries that can be built within the EM. So those are kind of the ways we think about the range of research that can occur in a PCBRN. So like other PBRNs, we actually really draw on the experience and the insight of practicing clinicians. So, these are grassroots, bottom-up types of organizations where we really go to the people at the front lines to ask them what they think are the most important and relevant questions that we should be asking or problems we should be trying to solve. Why this matters, research that's occurring at that front line of healthcare delivery can produce information and results that really drive where we go next. So it's very practical and close to the point of care. And that makes a distinction from more basic science or tertiary care cited studies where the direct applications may be a little further down the translational pathway or may apply to a very select group of tertiary care types of patients. So these networks of practices can serve as valuable labs for this kind of research. And then increasingly, we're seeing cross collaboration between PBRNs around the US. So, being from rural northern New England with, a pretty rural population and homogeneous racial and ethnic population, our results don't always translate well to other settings. So as we have been going forward, with the co-op, we are really looking for collaborations with other PBRNs, PCBRNs, where we can improve our generalizability in heterogeneity populations. So with that, I will stop and turn it over to Neil, and I'm assuming we'll wait for questions till the end.
And Charlie, are you okay, so you're sharing the screen, so I get to say next slide, please, to
Yes,
you, huh?
I'll
Okay,
anticipate as best I can.
thank you. Um, so um, just for a little more background, when I finished residency and started practice, I heard about this thing called the Dartmouth Co-op, which is what it was called at the time, as a way to do some research in my practice and decided to check it out. And that was the mid 1980s. And fortunately, I've been connected ever since, first as a clinician and now having the good fortune to work with the co-op as one of the research directors. There's several of us. So the first thing I'm going to do is go over at a high level a handful of co-op projects that have been done in the past that have had impact on healthcare locally, nationally, and in some cases globally. So next slide, please, Charlie. And these are all busy slides, and I'm gonna hit some highlights. So at the top right of this slide are some of the Dartmouth Co-op charts. And the co-op charts, which were developed in the 70s and 80s, one of the first things done by the co-op was number one, it was a very early effort at patient-reported outcome measures. These are all completed by the patient. And it was an early effort to measure function in primary care practice, which I think we are still not doing consistently. The co-op charts have been used all over the world. They were adopted by the World Congress of Primary Care, which is called WONCA. Interestingly, I just participated in a cardiac rehabilitation program at Maine Health, and I was handed a bunch of things to fill out at the beginning, which included the co-op charts. And I know how they got to Maine Health because I introduced them about 20 years ago. I didn't know they had found their way to cardiac rehab. So the co-op charts probably are the single thing. They've been around for 50 years and they've had an impact all over the world. There's been a lot of um, good work on practical ways, and these are these are categorized in a way that sort of overlaps to me. So I'll be talking about projects that don't necessarily line up with these categories. Thank you to my friends at Dartmouth for these slides, though. But there's been good work at improving our ability to take care of certain patient populations in primary care. The Teen Mental Health Project, which I remember was called Teen Screen, was one in which it was in the early days of digital health, and they were able to use computers to collect behavioral screening kind of data about adolescents and found that adolescents were much more comfortable talking to computers than to the people in the room. So that was the interesting finding from that. Under the optimizing the patient visit bullet, the Tools Teamwork and Tenacity project, which was a multi-year project of developing cancer um, screening and prevention activities in primary care practices, which eventually became a national project called Putting Prevention into Practice. So again, here was a project on cancer screening that started at the co-op and eventually grew to be a national project. Next slide, please, Charlie. Um, There's a number, I think the projects under observing our practice have to do with collecting data within the practice. One of them was the first project I ever did with the co-op, which was the Revisit Interval Project. It was a card study, which I'll talk about a little more. Um, but it essentially collected data from clinicians while we were seeing our patients about how frequently, or with patients with chronic illnesses, how often did we want to see them in follow-up? And that project did eventually get published. There's been a number of projects, and they're listed under community interventions, that are dually an intervention in a clinical and a community setting. Um, there was the project about testing for arsenic in wells. And then another project on which is not listed, but was a great combination of an intervention in pediatric practices, plus in some communities where those practices were located, to improve sun protection, use of sunscreens, things like that. And again, many of these projects led to publications and led to changes in primary care practice locally and across the country. Next slide, please, Charlie. So we're going to talk just a little bit, and I must say what's been going on at the federal level has been very disruptive to the plans of what is the co-op working on, what projects are available. So we unfortunately don't have as much to say at this point about current and ongoing projects as we would have liked to. But let's pull up the next slide, please, Charlie. So I talked about card studies, and card studies are essentially surveys of clinicians. Sometimes patients are surveyed as well, but that really the primary focus of card studies is to survey clinicians during the day of seeing patients. The survey is designed to take only a minute or two, so collecting data in some cases after each patient, in other cases after each patient who meets certain criteria. And what card studies really allow you to do is to gather data about what's going on in primary care practice, and in particular, to get into the thought process of the primary care clinicians. The Revisit Interval project that I mentioned earlier is an example that I know. So at the end of each visit with a patient who had high blood pressure, COPD, or diabetes, we indicated how many weeks or months it would be till we would see the patient again and what factors. And there was a checkoff list plus a fill in the blank kind of box to indicate what influenced our decision about how soon we're going to see this patient for management of their chronic condition. And so they were really able to see how clinicians thought about chronic care management of patients back in the 80s. We did indeed have two card studies that were in implementation. Unfortunately, the long COVID card study, which was funded by the CTR, um, because the CTR pilot funding was pulled, we're only going to be able to do the UVM part of that study because we had started it. One of the interesting studies, and Charlie was talking a little bit about secondary data analysis, but we have been doing work across Maine Health, Dartmouth, and UVM, since we all have Epic, to create a clinical database about primary care across those three organizations, initially using Trinetics, which I saw on the Echo list, I think is next month's topic. But each of the organizations was at some point at making data sets available in Trinetics. And so that will be the beginning of having a clinical data set about primary care practice that is available for health services researchers to query. We don't, the rules about how this is going to be used, I don't believe have been developed yet, but this is an exciting resource that's coming. There's funding needed. I don't know if that funding stream is going to continue to be active or not, but something exciting that's coming, potentially coming soon. Next slide, please, Charlie. And knowing that a lot of the people who attend this ECHO are researchers themselves, we have less primary care clinicians and researchers, I think, on this call. We wanted to share how the co-op can work with researchers who have projects and might want to work with primary care. One of the first things, and I know Connie's going to reinforce this in her comments as well, is if you think you might want to work with the co-op on a project, come talk to us early. We have a process. The research intake form that is number one on this slide is how you started. And basically, what it gets you to is to meet with the research staff of the co-op, which includes some of the research directors and the other implementation staff, to think about how to best take your research idea and work with a practice-based research network to make it successful. So if you're a researcher and you think that working with primary care practices might be useful to the direction that your research is going in, come talk to the co-op leadership early on, and let's see how we can all work together. Next slide, please. I know we're getting tight on time. The last thing is that you don't have to be a primary care clinician to be a member. If you're interested in primary care research, you can join the co-op, and this slide will tells you the various ways that you can get involved. I think this is our last slide, and we're ready for questions prior to the case.
And I'm going to signal we have a couple minutes, or if Connie's willing to give a little bit of her time, we can also circle back to this in the discussion time after the case. But if anyone has maybe a burning question right now. And while you're thinking about that, I'll invite Connie to maybe pull up her slides and we can transition to Kim introducing Connie.